Good evening. Thanks to BD Physician for giving me the opportunity. And today's topic is beyond the diagnosis, thriving with thyroid disorders. And uh, thyroid is a big topic, and I cannot cover whole thyroid thyroid, but I will cover in this presentation basic physiology and embryology, hypothyroidism, subclinical hypothyroidism, congenital hypothyroidism, thyrotoxicosis, and followed by there will be a short quiz of 5 questions. Okay, now we are starting. This thyroid word comes from the Greek word "thurios," because the shape of the thyroid gland is like the shape of the shield that was used in the ancient Greece. The thyroid gland develops from the ventral bulge, which is called thyroid anlage, between the first and second branchial arch from the floor of the pharynx. And then it migrates downwards from the foramen cecum to its final position in the neck. And ultimately, it fuses with ultimobranchial body that gives rise to C cell. So, the follicular cells of the thyroid gland derived from endodermal thickening from the ventral wall of the foregut, the C cell from the neural crest cells, and the blood vessels and connective tissue from the hypobranchial mesoderm. Now, how the thyroid hormone synthesis occurs? First, there is active transport of iodide, which is transported by sodium iodide importer, which is called iodide trapping. Then that iodide is transferred into the colloid by the pendrin, and due to defect in this pendrin, there is pendrin syndrome. Then there is organification, which form the monoiodotyrosine and diiodotyrosine. Then coupling occurs, and T4 and T3 is formed. Then thyroid hormone is stored within the colloid, and due to stimulus, there is release of thyroid hormone. Then proteolysis of the thyroglobulin with release of free iodothyronine and iodotyrosine into the circulation. And then deiodination of tyrosine by iodotyrosine dehalogenase within the thyroid cells, which will reuse the liberated iodine. And ultimately, the T4 is converted to T3 by 5' monodeiodinase. This is the whole procedure of thyroid hormone synthesis. Now, the first topic, hypothyroidism. Hypothyroidism is the insufficient secretion of thyroid hormone. However, when there is severe hypothyroidism associated with accumulation of hydrophilic mucopolysaccharides in the ground substance of the dermis and other tissue, with thickening of the facial features and duffy induration of the skin, that is called mixedema. There are some risk factors for developing hypothyroidism. They are older people, women, white individuals, presence of other autoimmune disease, Down syndrome and Turner syndrome. However, in some of the studies, it has been found that tobacco smoking and moderate alcohol intake has been associated with reduced risk of hypothyroidism. The hypothyroidism can be classified in various ways. Firstly, primary central peripheral, in which the main problem is within the thyroid gland. In the central, the problem in the other than thyroid gland. It may be secondary due to deficiency of TSH or due to tertiary, where the deficiency is thyrotropin releasing hormone. And another one is peripheral, in which there may be conjunctive defect in conversion of T4 to T3 and resistance to thyroid hormone. Among the primary defect, it constitutes 99%. And it can be divided into acquired and congenital defect. Among the acquired, there is Hashimoto thyroiditis, iodine deficiency, drugs cause goitrogens, cytokines, some thyroid infiltration disease like amyloidosis, hemochromatosis, sarcoidosis, post-ablative thyroiditis, and transient hypothyroidism. Also, hypothyroidism can be classified by non-goitrous and goitrous. The non-goitrous causes are post-ablative, congenital developmental defect, atrophic thyroiditis, and post-radiation. And goitrous hypothyroidism causes are Hashimoto thyroiditis, decurvance thyroiditis, severe iodine deficiency, drug elicited, hemochromatosis, and maternally transmitted antithyroid agents and iodine. The clinical features. Usually, the symptoms and symptoms of hypothyroidism develops are insidious and non-specific onset. There may be fatigue, lethargy, constipation, cold intolerance, muscle stiffness, and cramps. There may be carpal tunnel syndrome. Women usually develop initially menorrhagia, but later oligomenorrhea or amenorrhea can develop. There is slowing of intellectual and motor activities, decreased appetite and weight gain. There will be dry skin with hair loss, deep hoarse voice, and obstructive sleep apnea. However, in case of myxedema, there will be dull, expressionless face with sparse hair and periorbital puffiness. Macroglossia, pale, cool skin that feels rough and duffy, enlarged heart with dilatation and pericardial effusion. Megacolon, cerebral ataxia, prolonged relaxation phase of deep tendon reflex. There will be peripheral neuropathy, encephalopathy, hyperlipidemia, hyperkeratonemia, and psychiatric symptoms like depression and psychosis. So, how to improve? In hypothyroidism, it is better to do pair test, both TSH and FT4. If strong suspicion of hypothyroidism, goiter present, and suspected central hypothyroidism. As primary hypothyroidism progress, TSH increase, free T4 falls, but free T3 does not fall until the severe hypothyroidism because preferential synthesis and secretion of T3 by residual functioning thyroid tissue under the increased TSH stimulation and increased conversion of T4 to T3 by increased efficiency of monodeiodinase enzyme. So how to evaluate? We will do TSH, FT4 and anti-T2 antibody. Whenever the TSH is more than 10 with low free T4 and anti-T2 antibody is positive, the most likely cause is primary autoimmune hypothyroidism. However, if anti-T2 antibody positive with TSH more than 10, but free T4 is low normal, this may be primary autoimmune subclinical hypothyroidism, which may progress into permanent hypothyroidism in the later phase. But if free T4 is low or low normal, but anti-T2 antibody may negative, there may be some cause other than hypothyroidism, like recovery from systemic illness, external irradiation, drug-induced cause, iodine deficiency, infiltrative disease, recovery from subacute granulomatous thyroiditis. However, if free T4 and TSH both are elevated, it may be due to thyroid hormone resistance, blockade of T4 to T3 conversion by amiodarone, and assay artifacts. When the TSH is between 5 to 10 and anti-T2 antibody is positive, but free T4 is low or low normal, it may indicate early primary autoimmune hypothyroidism. Whenever TSH is 0.5 to 5, but FT4 is low, that means the TSH is inappropriately normal. This may indicate central hypothyroidism. And whenever TSH is low and FT4 both are low, it may be due to central hypothyroidism, post-hyperthyroid hypothyroidism, T3 or desiccated thyroid excess, or following excess levothyroxine withdrawal. This is the flow chart. Whenever feature sensitive hypothyroidism is found, same TSH and FT4 should be done. If TSH increased and FT4 low or low normal, it usually indicates primary hypothyroidism. In that case, if T2 antibody positive, the diagnosis will be Hashimoto disease. If TP antibody is negative, it may be transient hypothyroidism or still it may be Hashimoto disease, as 10 to 15% cases of Hashimoto disease can be antibody negative. Then in that case, levothyroxine should be started. And if in the latter part, after 6 weeks, by checking the TSH, levothyroxine can be reduced. If TSH is increased, then permanent hypothyroidism is confirmed. However, if TSH is normal or low and FT4 is low or low normal, then it may be a cause of central hypothyroidism. Then MRI should be done. And in MRI, there may be pituitary or hypothalamic lesion. And if there is pituitary or hypothalamic lesion, then other hormonal axis should be checked, like adrenal, prolactin, and gonad. And in that case, thyroid hormone should not be given prior to cortisol replacement. There may be some biochemical abnormalities in case of hypothyroidism, like raised creatinine kinase, raised LDL cholesterol, lipoprotein A, raised AST and LDH, and there is anemia and hyponatremia. So that treatment. The thyroid hormone replacement with synthetic levothyroxine is the treatment of choice. Levothyroxine has a long half-life, which enables it if the patient forgot to take any dose, he can take 2 doses at once if a dose is omitted. Normal metabolic state should be restored gradually, as rapid increase in metabolic rate may precipitate cardiac arrhythmia. The average replacement dose is 1.6 to 1.8, usually 1.7 microgram per kg per day. In the younger patients, levothyroxine should be started at a 50 to 100 microgram dose, but in the elderly with a history of ischemic heart disease, it is wise to start levothyroxine dose slowly. Usually 25 microgram can be given and then 12.5 to 25 microgram increment at 4 weekly interval until normal metabolic state and TSH are attained. The optimum dose is determined by clinical criteria, with the objective of treatment being to restore serum TSH within the normal range. The TSH should be checked 6 weeks after any dose change. Once stabilized, serum TSH should be checked on an annual basis. Some symptoms such as lethargy or myalgia may take up to 6 months to fully recover. In those patients who remain symptomatic and in whom serum TSH remains towards the upper end of the reference range, it is usual practice for the dose of levothyroxine to be slightly increased to target a serum TSH at the lower end of the reference range, that is less than 2.5 milliunit per liter. Patients with iatrogenic hyperthyroidism have an increased risk of arrhythmia and fractures, so it is wise to be avoided. In patients with secondary hypothyroidism, free T4 is the most useful parameter to follow. In that case, TSH has no value in follow. The dose requirement can be increased by 25% in 25 to 50% in pregnancy due to increase in thyroxine binding globulin. Elevated TSH, despite levothyroxine replacement, is common, most usually due to lack of compliance. If TSH is still elevated when thyroxine load at 1.6 microgram per kg per day or higher, the careful questioning of compliance is needed. Levothyroxine should be administered with water on an empty stomach at least 30 minutes before breakfast and avoiding other medications like iron, calcium, and PPI. Some disease states which interferes with levothyroxine absorption include celiac disease, pernicious anemia, gastritis, or malabsorption. Sometimes, rarely, Addison's disease can present as a sudden rise in serum TSH. Raised free T4 and raised serum TSH level can be seen in a patient poorly compliant with levothyroxine, who recommends levothyroxine treatment shortly before a blood test. And thyroid function test should be performed at the same time of the day each time, as there is a diurnal variation in serum TSH level. Now, the second topic, subclinical hypothyroidism. It is biochemically when there is slightly elevated TSH with low normal free T4. However, this subclinical hypothyroidism has increased risk of progression to overt hypothyroidism, that is 2 to 6% per year, and it is more common in female with higher TSH value, with higher anti-T2 antibody and low normal free T4. Before diagnosis of subclinical hypothyroidism, the transient causes of elevated TSH level should be excluded by repeated measurement after 2 to 3 months, which may be recovery from non-thyroidal illness, recovery phase of thyroiditis, and drug cause like amiodarone and lithium. So, how to treat subclinical hypothyroidism? Start levothyroxine 25 to 75 microgram per day, depending on the TSH level. If there is history of angina or cardiovascular risk factors, the initial dose should be 25 microgram per day. The level TSH and FT4 level should be checked at 4 to 8 weeks. The target TSH is in young patients 0.5 to 2.5 milliunit per liter, and in case of older patients 4 to 6 milliunit per liter. However, overtreatment has some increased risk of atrial fibrillation, osteoporosis, and fractures in age more than 60 years. This is the algorithm when to start treatment in case of subclinical hypothyroidism. When the TSH is more than 10, thyroxine should be started. But when the TSH is between 7 to 9.9, if the patient's age is more than 65 without any convincing symptoms of hypothyroidism, we can observe the patient. But when the TSH value is 7 to 9.9 and patient's age is less than 65, then thyroxine treatment should be started. When the TSH value is less than 6.9 and the patient's age is more than 65, the TSH is age appropriate. In this case, treatment is not recommended. However, if the patient's age is less than 65 with convincing symptoms of hypothyroidism, levothyroxine treatment can be initiated. Now, the third topic, congenital hypothyroidism. The incidence of congenital hypothyroidism is 1 in 3,500 to 4,000 years. And among these, 85% is due to defective ontogeny, that is, thyroid dysgenesis due to ectopic thyroid, athyrosis, or thyroid hypoplasia, and 15% due to dyshormonogenesis. These are the clinical features. The common clinical features are feeding problem, prolonged jaundice, mottled dry skin, open posterior frontally, puffy face, enlarged tongue, umbilical hernia, pot belly, and muscular hypotonia. And there are some rare clinical features like obstipation, that is severe constipation, respiratory distress, bradycardia, hypothermia, low pitched voice, and hypoactivity. However, what is cretinism? Cretinism is the severe and irreversible growth and mental retardation of a child due to congenital hypothyroidism. This is the algorithm for neonatal screening. It is advised to do filter paper blood spot test. The primary T4. When the primary T4 is more than 10%, it is not management. But when the T4 is less than 10%, TSH test should be done. I'm not going any deep. So how to treat? The primary hypothyroidism treatment should be initiated before 2 weeks. And in this case, in adult, the dose is 1.7 microgram per kg per day. But in case of congenital hypothyroidism, the dose is very high. In 0 to 3 months, the dose is 10 to 15 microgram per kg. Between 3 to 12 months, 6 to 10. Between 1 to 3 years, 4 to 5 microgram per kg body weight. Between 3 to 10 years, 3 to 5 microgram per kg body weight. And then between 10 to 16 years, the dose is 2 to 4 microgram per kg per body weight. And the monitoring is more frequent in this congenital hypothyroidism. First weekly for 1 month, then 2 weekly interval thereafter, and then monthly up to the 6 month, and at 3 months interval from 6 months age onwards. However, when there is secondary hypothyroidism, the lower dose is required, usually 7 to 8 microgram per kg body weight. And in case of secondary hypothyroidism, cortisol replacement given before 10 to 12 milligram per meter square body surface area. Now, the next topic is thyrotoxicosis. There is two terms, thyrotoxicosis and hyperthyroidism. Two terms are different. The thyrotoxicosis is a hypermetabolic state due to excessive thyroid hormone at tissue level. But in hyperthyroidism, there is thyrotoxicosis due to overproduction of thyroid hormone by thyroid gland. So, in case of thyrotoxicosis, the source of thyroid hormone may not be from thyroid. It may be from elsewhere. So, all hyperthyroidism states are thyrotoxicosis, but all thyrotoxicosis states are not hyperthyroidism. Now, the causes of thyrotoxicosis. There may be thyrotoxicosis with hyperthyroidism and thyrotoxicosis without hyperthyroidism. Among the causes of thyrotoxicosis with hyperthyroidism, the causes are excessive TSH receptor exposure from Graves' disease, gestational transient thyrotoxicosis, trophoblastic disease, TSHO, and autonomous thyroid hormone secretion from toxic multinodular goiter and autonomously functioning thyroid nodule. So, in case of thyrotoxicosis with hyperthyroidism, the source of excess thyroid hormone is from the thyroid gland. Now, the thyrotoxicosis without hyperthyroidism. In this case, in this thyrotoxicosis without hyperthyroidism, the thyroid gland is not overactive. It may be due to destructive thyroiditis or extrathyroidal source of thyroid hormone. Among the destructive thyroiditis, there may be subacute decubitus thyroiditis, painless postpartum thyroiditis, acute thyroiditis, or drug-induced thyroiditis. And extrathyroidal source of thyroid hormone may be iatrogenic over-replacement with thyroid hormone, food and supplements containing excessive thyroid hormone, functional thyroid cancer metastasis, and stroma ovary. Thyrotoxicosis can be classified according to radioactive iodine uptake. Excess thyroid hormone with high radioactive iodine uptake and excess thyroid hormone with low radioactive iodine uptake. So, with high radioiodine uptake causes are Graves' disease, toxic multinodular goiter, toxic adenoma, and TSH producing pituitary adrenal. However, with low radioiodine uptake causes are subacute thyroiditis, postpartum thyroiditis, exogenous hormone intake, stroma ovary, metastatic follicular thyroid carcinoma, or amiodarone or drug or iodine induced. Now, some pathophysiology of some causes of thyrotoxicosis. The diffuse toxic goiter, the Graves' disease, it is usually autoimmune disease, accounts for 80% cases of thyrotoxicosis. There is abnormal thyroid stimulating antibody to TSH receptor. 50% cases are familial, mostly occurs in young female, and there is primary thyrotoxicosis with eye signs. Toxic multinodular goiter. only 5% of all cases, 10 times more 10 times more common in iodine deficient area. Typically occurs in patients older than 40 years with long-standing goiter. Activation mutation of TSH receptor or GS alpha and secondary thyrotoxicosis, eye signs are rare. Now, the toxic adrenal, more common in young patients, autonomous functioning single nodule. Size usually more than 3 centimeter, visualized as a hot nodule on radioactive iodine uptake scanner. Subacute thyroiditis. There is abrupt onset due to leakage of preformed disorder. For the first 4 to 6 weeks, so subacute in subacute it is usually a triphasic disorder. That means there are 3 phases. First, for the first 4 to 6 weeks, there will be increased thyroid hormone, which causes thyrotoxic phase. Then, for the second 4 to 6 month period, it is hypothyroid phase, and lastly, patient becomes euthyroid. And the outcome, usually in 90% cases, it completely recovers, and in 10% of cases, if in some participant patients in which anti-TPO antibody is positive, there may be development of hypothyroidism. Amiodarone-induced thyroiditis. Amiodarone can cause both hypothyroid and hyperthyroid. It causes hypothyroidism due to failure to escape from Wolff-Chaikoff effect, and hyperthyroid due to Jod-based phenomenon. The hyperthyroid is 2 types, type 1 and type 2. In type 1, in the background of autoimmune disease, that means patient has already had some form of autoimmune disease in thyroid in iodine deficient area, and in type 2 it is destructive thyroiditis. So what is Wolff-Chaikoff effect and what is Jod-based phenomenon? Wolff-Chaikoff effect. Whenever thyroid gland is exposed to excess iodine, there is transient inhibition of thyroid hormone synthesis because this iodine forms organic iodo compound and causes suppression of thyroid peroxidase activity. However, this inhibitory effect is not permanent, it is usually temporary. After about 5 to 7 days, the inhibitory effect of iodine on thyroid hormone biosynthesis resolves, and it is called iodide escape. This iodide escape occurs because this iodine-mediated downregulation of sodium iodide symptoter occurs, and which prevents further iodine influx into the glands. However, in some patients taking amiodarone, there is persistence of Wolff-Chaikoff effect because the downregulation of sodium iodide symptoter cannot occur in that patients. So the iodine influx cannot be prevented and the Wolff-Chaikoff effect persists, and which causes hypothyroidism. And this is the Jod-based phenomenon in which iodine supplementation in an iodine deficient area result in a development of hyperthyroidism. And this iodine acts as a fuel to fire. So now the manifestations of hyperthyroidism. The symptoms are hyperactivity, irritability, altered mood, insomnia, heat intolerance, increased sweating, palpitation, fatigue and weakness, dyspnea, weight loss with increased appetite, pruritus, increased stool frequency, thirst and polyuria, oligomenorrhea or amenorrhea, loss of libido, and erectile dysfunction. About 50% of men may have sexual dysfunction. The signs are sinus tachycardia, atrial fibrillation, fine tremor, hyperkinesia, hyperreflexia, warm, moist skin, palmar edema, onycholysis, hair loss, muscle weakness and wasting. There may be congestive high output heart failure, chorea, periodic paralysis, primarily in Asian male, and rarely psychosis. These are the eye signs. Lid retraction and lid lag. These two symptoms occurs. These two signs occurs due to sympathetic overactivity. There may be periorbital puffiness, difficulty in eversion of upper lid, infrequent blinking, absent crease on forehead on superior gaze, and difficulty in convergence. So now the investigations. First, uh, first, whenever symptoms of hyperthyroidism, we have to evaluate the patient whether there is new onset, if there is presence of new onset thyroid eye disease, large non-nodular thyroid, moderate to severe hyperthyroidism. If the clinical presentation is consistent with Graves' disease, like there is bruit, there is eye signs, and there is diffuse toxic goiter, then the diagnosis is Graves. But if the patient does not show any definitive signs of Graves' disease and the patient has a nodular goiter, then we have to do radioactive iodine uptake and scan. And if the patient has no goiter, then we can do thyroid receptor antibody, that is TRAB. If TRAB is positive, the diagnosis is Graves' disease. But if TRAB is negative, then radioactive iodine uptake and scan, or if expert ultrasonography is present, then thyroid ultrasound can be done. In the radioactive iodine uptake and scan, uptake high or normal suggests Graves' disease, in which there will be diffuse uptake. Toxic multinodular goiter, there will be patchy uptake, and toxic adenoma, there will be focal uptake. An uptake low or nearly absent will suggest thyroiditis, extrathyroidal source of thyroid hormone, or iodine-induced thyrotoxicosis. If expertise is present, then ultrasound can also be done to see the peak flow of inferior thyroid artery. In Graves' disease, the peak flow of inferior thyroid artery is usually raised. This is the radioiodine scan photo. The first photo shows a cold nodule. In the second picture shows, upper second picture shows diffuse increased uptake in both thyroid gland, that is Graves' disease. In the upper third, that is toxic multinodular goiter due to patchy uptake. In the lower panel, first picture shows a hot nodule, but the remaining of the gland activity is shown. However, in the lower second picture, there is suppression of the remainder of the gland. This is autonomous nodule. And the last picture shows no uptake, which is no or low uptake, which is thyroiditis. This is the Doppler ultrasonogram. At the peak systolic velocity of inferior thyroid artery, more than 40 centimeter per second indicates Graves' disease. And this increased vascularity is a sign of Graves' disease. And this is called thyroid inferno. So now treatment. The goal is to correct hypermetabolic state with least side effects and lowest incidence of hypothyroidism. Treatment depends upon cause and severity of disease, patient's age, goiter size, comorbid conditions, and treatment desired. There are three options: antithyroid drug, radioactive iodine, and surgery. As adjunct, beta blocker and iodides can be used. Now, the antithyroid drugs. The antithyroid drugs primarily interfere with uptake and organification of iodine. and suppress the thyroid hormone. There are two agents, carbimazole and propylthiouracil. When to give antithyroid drugs as a short-term therapy to prepare patient for radioactive iodine or therapy or surgery, for medium-term therapy for remission in Graves' disease. However, relapse is common in antithyroid drug and relapse is more common in smoker, male, age less than 40 years, large goiter, high titer TRAC positive patients. There are some complications like agranulocytosis, which can occur up to 0.5% of cases, and it is more, the chances are more with propylthiouracil. And during giving antithyroid drug, patients are usually advised to stop the drug if sudden fever or sore throat appear and consult with doctor. Some other complications are hepatitis, skin rash, and lupus-like syndromes. As adjunct, beta blocker can be used. Beta blocker causes prompt relief of adrenergic symptoms. The propranolol is widely used. The starting dose is 10 to 20 milligram 4 hourly, 6 hourly, and increased progressively until symptoms are controlled. Most cases, 80 to 320 milligram is sufficient. If beta blocker cannot be tolerated or contraindicated, calcium channel blocker can be used. Iodide blocks peripheral conversion of T4 to T3 and inhibits hormone release. Iodides are used as adjunct therapy before emergency non-thyroid surgery. Beta blockers cannot curtail symptoms or if decrease vascularity before surgery for Graves' disease. Now, radioactive iodine. This is the treatment of choice for Graves' disease and toxic multinodular goiter, as it is inexpensive, highly effective, easy to administer, safe. Dose depends on estimated weight of the gland, and higher dose increases success rates but higher chance of hypothyroidism. Higher dose is favored in older patients. Dose individualization is difficult. Arbitrary dose is 200 to 600 megabecquerel, effective for both Graves' disease and toxic multinodular goiter. And one of the side effects is transient thyroiditis. Now, the last option is surgery. Surgery is indicated when there is large toxic multinodular goiter, large diffuse toxic goiter, toxic adenoma, childhood Graves' disease, and thyrotoxicity in pregnancy during the second trimester. There are some newer therapy which includes minimally invasive subtotal thyroidectomy, embolization of thyroid artery, plasmapheresis, percutaneous ethanol injection into the toxic nodule, L-carnitine supplementation may improve symptoms and may prevent bone loss. Okay, so that is all about my presentation.
আমি জাস্ট দুই তিনটা কোশ্চেন। আচ্ছা, একজন কোশ্চেন করেছে ফেট অফ কনজেনিটাল হাইপোথাইরয়েডিজম, এটা ফেট কি আসলে? এটা কি একসময় ভালো হয়ে যায় নাকি সারা জীবন হাইপোই থেকে যায়?
Congenital hypothyroidism.
এটা ফেট কি?
Congenital hypothyroidism থাইরয়েড ট্রিটমেন্ট নিতে হবে আজ লাইফ লং। এটা ডিসহরমোনাইজেশনের জন্য হতে পারে, নয়তো থাইরয়েড এমব্রায়োলজিক্যালি যদি থাইরয়েড একটোপিক থাইরয়েড অথবা অ্যাথাইরোসিস, থাইরয়েড ট্রিটমেন্ট লাইফ লং নিতে হবে। এবং এই ক্ষেত্রে কনজেনিটাল হাইপোথাইরয়েডিজমের ট্রিটমেন্ট যদি ইনিশিয়ালি 2 উইকসের মধ্যে শুরু করা না হয়, সেক্ষেত্রে মেন্টাল ডিটারেশন থেকে শুরু করে অন্যান্য অ্যাবনর্মালিটিগুলো দেখা দেবে। এই জন্য যখনই সাসপেনশন থাকবে, বেটার টু স্টার্ট থাইরক্সিন অ্যান্ড দেন কনফার্ম পরেও করা যাবে, কিন্তু এক্ষেত্রে লেট করাটা খুবই।
সো এটা খুব ইম্পর্টেন্ট পয়েন্ট। সো কনজেনিটাল
আরেকটা আছে, কনজেনিটাল হাইপোথাইরয়েডিজমের সাথে
তার মানে একটা বাচ্চা সারা জীবনের জন্য হয়ে যেতে পারে আর কি।
এটার সাথে একটা কনফিউশন হতে পারে, ট্রানজিয়েন্ট হাইপোথাইরয়েডিজম হতে পারে। সেক্ষেত্রে টিএসএইচ ভ্যালু দিয়ে ওইটা বোঝা যাবে। দুইটার মধ্যে একটু কনজেনিটাল হাইপোথাইরয়েডিজম আছে, আরেকটা আছে ট্রানজিয়েন্ট হাইপোথাইরয়েডিজম।
আর একটা কোশ্চেন, যে এটা তুমি বলছো যে মানে 65 এর বেশি হইলে নো ট্রিটমেন্ট অফ সাবক্লিনিক্যাল হাইপোথাইরয়েডিজম, এটার ব্যাখ্যা কি?
সরি, কোশ্চেনটা বুঝিনি।
মানে একজন কোশ্চেন করেছে যে মোর দেন 65 ইয়ার হইলে এসসিএইচ এর ট্রিটমেন্ট লাগবে না, বলছো নো ট্রিটমেন্ট।
সেই ক্ষেত্রে না না, আমি বলেছি আচ্ছা, আমি দেখাই তাহলে স্লাইডটা।
ওকে,
টিএসএইচ ভ্যালু যখন 10-এর বেশি থাকতেছে, 10-এর বেশি থাকতেছে, আমি ট্রিটমেন্ট শুরু করে দিব। কিন্তু যখন টিএসএইচ টিএসএইচ ভ্যালু 7 to 9.9, মোর দ্যান 65-এ যদি কনভিন্সিং সিমটমস অফ হাইপোথাইরয়েডিজম না থাকে, ট্রিটমেন্ট শুরু করব না। কারণ যত এজ বাড়বে টিএসএইচ এর রেফারেন্স রেঞ্জ
ওকে,
তত বেড়ে
এখানে
যায়।
ফ্যাক্টর হচ্ছে সিমটমস না থাকলে করব না
সিমটম।
এইটা। ওকে ওকে, দ্যাটস ইট। ওকে ওকে, লাস্ট একটা কোশ্চেন দিয়ে আমরা শেষ করি। জাস্ট একজন একটা কেস সিনারিও দিছে যে অ্যাকর্ডিং টু দ্য রিপোর্ট মাই প্যাশেন্ট হ্যাড টিএসএইচ 8.53 and after 2 months with proper treatment TSH was 14.3. Can it possible due to any cause or lab errors? ট্রিটমেন্ট দেওয়ার পর বেড়ে গেছে। ওকে,
এটা হ্যালো, শোনা যাচ্ছে?
হ্যাঁ শোনা যাচ্ছে, বলো।
হ্যাঁ, এই ক্ষেত্রে একটা হতে পারে লেভোথাইরক্সিন ডোজ যেটা দেওয়ার কথা 1.7 মাইক্রোগ্রাম পার কেজি পার ডে বডি ওয়েট, সেই এডুকেট ডোজে পাচ্ছে না, 1 নাম্বার। 2 নাম্বার, পেশেন্টের কমপ্লায়েন্স ঠিক মতো হচ্ছে না। 3 নাম্বার হতে পারে যদি পেশেন্ট সাথে ক্যালসিয়াম আয়রন ট্যাবলেট বা পিপিআই 4 ঘন্টার মধ্যে খেয়ে থাকে, তাহলে ঠিক মতো অ্যাবজর্পশন হবে না। এবং আরেকটা হতে পারে যে অ্যাসোসিয়েটেড কোনো গ্যাস্ট্রাইটিস, সিলিয়াক ডিজিজ, কোনো অ্যাবজর্পশনের প্রবলেম থাকতে পারে। ওগুলো আসলে এইভাবে করা লাগবে। আর অবশ্যই ল্যাবের টেস্টটা তো করা লাগবে। তবে এটা মোস্ট কমন যে থাইরক্সিন সাপ্লিমেন্টেশনটা কারেক্ট ডোজে দেওয়া হচ্ছে না।
ওকে আজমল, থ্যাংক ইউ ভেরি মাচ। তো তোমার আমাদের সাথে এটা যাত্রা শুরু হইলো, ইনশাল্লাহ এই যাত্রা চলতে থাকবে।
থ্যাংক ইউ স্যার। আসসালামু আলাইকুম।
ওকে।